Hello, my name is Andrew Ward. I am a nurse practitioner here at UT with the Surgical Oncology group. I have been with Surgical Oncology now for the past 7 years, and prior to that did family practice as a nurse practitioner, and then even before that as well. I have been asked to give grand rounds this month for nursing, and recently have gone through extra training to provide hereditary cancer risk assessment and genetic management of high-risk patients to our patients in the Cancer Institute. So as a result, I've chosen to talk about hereditary cancer risk and the role of nursing for this month's topic. Here you'll see an outline of what our talk will entail. But first, let's talk about what cancer genetics is. There are really two types of cancer genetics. There are cancer genetics where we look at genetic mutations within a tumor that will often drive treatment options for patients. That is called somatic genetics, and that is not what we're talking about today. Conversely, there's also germline genetic mutations that can increase an individual's risk for cancer, and that's what we're here to talk about. We're going to talk about the very basics of genetics, just to give a foundation from which to understand the rest of this lecture. We're going to talk about the importance of taking a family history and the relevance of that for genetic risk assessment. And then we're going to focus on the real main genetic cancer syndromes, so hereditary colon and rectal cancer, hereditary breast and ovarian cancer, and then just a few other things that we commonly see in practice and you may not necessarily think are influenced by genetics or may not know how much they're influenced by genetics. And of course, this is being recorded so that you can receive continuing education credits. So on this screen is a listing of our objectives for this talk. So we're going to, again, review the basics of genetics. We're going to talk about the importance of taking a family history and the relevance of that to genetic risk assessment for patients at an increased risk for cancer malignancy syndromes. We're going to talk about hereditary breast and ovarian cancer, hereditary colorectal cancer syndromes, genodermatoses. We're going to define that and talk about their relevance to genetic syndromes. And we're going to talk about a few other genetically influenced cancer syndromes. But first, let's talk about the basics, and we have to really break down into units as far as what we're actually talking about. So we're talking about genes, we're talking about DNA, we're talking about RNA and proteins. In regards to genes, those are the basic building blocks of our genetic makeup, and we all carry around 40,000 different genes within us that code for specific things, mostly enzymes. DNA is that substance of heredity. It's where our genetic information is carried within the cell. RNA is similar to DNA in that it is made up of 4 base pairs, but where DNA is made of A, C, T, and G, RNA is made of A, C, U, and G, where that T and U are different between the two molecules. RNA is also a single-stranded molecule, whereas DNA is a double-stranded molecule, which was illustrated on the previous slide in the background picture. RNA delivers DNA's genetic message into the cytoplasm of the cell, where then proteins are made. And then proteins are those molecules that are assembled under the direction of a gene that then have a function or a purpose in the body's activities. Genetic mutations come in many different forms, but basically these are aberrant forms within the DNA that will affect the normal function of a gene. So there could be base substitutions where there's a silent mutation. So one base pair is substituted for another base, and that doesn't result in any kind of change. So it is indeed a mutation, but it doesn't affect function. There are also missense and nonsense mutations where those base pairs change, but then the gene no longer works. There are deletions of genes, there are insertions of genes, there are splice site mutations, intergenic deletions, so deletions of portions within the gene, and then duplications of the chromosome or even translocation of the chromosome or a flipping of the chromosome. It's important to understand the difference between homozygous and heterozygous in reference to the rest of our talk because of patterns of inheritance. So that goes back to those Mendelian patterns of inheritance that we learned about in school. So just for reference, that was that German priest that played with pea plants and crossbred pea plants where we got these concepts from. Homozygous individuals have a copy of the same gene or the same mutation on each allele, whereas heterozygous individuals will have a normal allele and then a mutant allele. So they differ between the two alleles. Our genotype is our genetic constitution, so that's what our genes are. So if you looked at the code, you're literally looking at the code, whereas our phenotype is what's expressed. So I may have the genetic information inside of me for the potential to have brown eyes, when in fact I also have the potential for blue, and my phenotype is that I have blue eyes. Now, our phenotype is influenced by our genetic code or our genotype, but it's also influenced by our environment. Most of the mutations that we're going to discuss are autosomal dominant. So mutations such as hereditary breast cancer with BRCA1 or 2 mutations, hereditary colorectal syndromes such as Lynch syndrome with MLH1, MSH2, MSH6, and PMS2 mutations, and Cowden syndrome or a mutation in PTEN. But there's also autosomal recessive mutations such as MYH-associated polyposis, which we'll talk about later. Now, there are some exceptions. There is a concept of mosaicism where the individual in question received a normal copy of genes from both parents, and then at some point during development in utero, there was something that occurred and mutations occurred. So that individual, as they grow and develop, they have copies of normal genes as well as mutant genes circulating within them. These individuals may never express a trait that they have a mutation for, but they may have an increased potential, but more importantly, they have a potential to pass that mutation on to offspring later on. This again reinforces the importance of doing a family history, which we'll talk about in the next slide. The final thing to consider is there's also a concept of de novo mutations, and this is when a mutation occurs for the first time in an individual. So their parents have never had mutations, and there's no mutations or no cancer history in their pedigree, but they indeed have a genetic mutation that increases their risk for malignancy. We'll talk about a specific example of this later in the talk. So our next slide looks at the importance of taking a family history. And this is really key to doing genetic risk assessment to help determine what best tests to offer to a patient. And I think this puts us as nurses in a very unique and powerful role to provide this service to our patients. I think we do an excellent job at getting to a granular level of detail with our patients with family history, with physical exam, with past medical history that uniquely qualifies and situates us to provide this service to our patients. Past medical history for these patients is only one piece of the puzzle, as we just talked about in the previous slide. Yes, it's important, but that family history really drives what tests we may offer to our patients with genetic testing. And finally, in addition to documenting a patient's family history, it's very important to know what their ethnicity was, as this may increase their risk for certain genetic mutations, and also to ask about a concept called consanguinity, which is mixing of the blood or potential ancestral relations that may have occurred in the past that could have had an influence on the overall genetic makeup that a patient may have inherited. So now to talk about the actual syndromes themselves, we're going to start with hereditary breast and ovarian cancer. And most commonly, people associate mutations with the genes of BRCA1 and 2 with hereditary cancer of the breast and ovaries, when in fact mutations with these two genes account for only 80% of those genetic-driven cancers with these syndromes. So specifically, BRCA1 accounts for 50%, BRCA2 accounts for 30%, and then the other genes that were listed on the slide account for the remaining 20%. BRCA1 and 2 were the first genes identified to make an individual an increased risk for hereditary breast and ovarian cancer. They were identified back in the 1990s, and because they've been around or known for so long, we've identified to date over 2,000 mutations in these two genes alone that increase an individual's risk for hereditary breast and ovarian cancer. Now, also because we've known about these mutations for so long, we know that there is a new phenomenon called founder effect, where when individuals are from a certain ethnic background that was a closed group in the past, they have characteristic mutations in these genes. And the example that's most commonly known is the Ashkenazi Jewish population. This traditionally was a very closed population. They married within their own group, and as a result, there was not a lot of genetic variability, and the mutations that were present were passed on from generation to generation. Overall, if a person has a mutation in BRCA1 or 2, they have an overall lifetime risk of breast cancer ranging from 50 to 85%. If they have a known breast cancer, they have a risk of recurrence or a new breast cancer in the future, depending on their surgical decision, of anywhere from 40 to 60%. So this really goes to show it's very important to know the status of this mutation prior to a patient's decision making if they are ever affected by cancer. That could certainly alter what decision they make and ultimately reduce their future risk of a recurrent or a new malignancy. The overall risk for ovarian cancer in these individuals is 15 to 45%. Genes BRCA1 and 2 are considered high penetrance genes. That concept means if you have a mutation in that gene, you're much more likely to demonstrate that trait. So in this instance, we're talking about a risk for breast or ovarian cancer. Individuals with genetic mutations in these genes are more likely to have a cancer in their future than individuals with mutations in moderate penetrant genes, which are also listed on this page. And therefore, what we offer as far as management differs greatly depending on an individual's mutation. So individuals with a highly penetrant mutation, if they've never been affected by cancer, they never have had a diagnosis, they may be offered at the extreme. They may be offered prophylactic surgery before a cancer diagnosis, which would include bilateral mastectomy or even bilateral salpingo oophorectomy to reduce their ovarian cancer risk. But moderate penetrant individuals won't be offered surgery, but they could be offered risk reduction medications, such as anti-hormonal medications, and certainly would be offered high-risk screening in regards to mammography, alternating with MRI every 6 months. Unfortunately, with these mutations, we know that these individuals are at a greater risk for other cancers. So individuals with a BRCA mutation are also at risk for prostate cancer, if they're male breast cancer, fallopian tube cancer, and pancreatic cancer. The other gene mutations increase an individual's risk to thyroid cancer, endometrial cancer, colorectal cancer, brain cancer, sarcoma, adrenal malignancies, gastric cancers, pancreatic cancers, and ovarian cancer. So it's important to know a patient's history and their family history to know really which one of these you're focusing on when you're assessing a patient's risk. We start with the one that's not associated with polyps, and that's called hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. These individuals are at an increased risk compared to the general population for colorectal cancer as well as endometrial cancer, but they are also at risk for ovarian, stomach, small bowel, hepatobiliary, renal, ureter, brain, and sebaceous neoplasms. It's important to know if an individual is affected by this before they're affected by cancer, because it really could change the surgery that they're offered. Individuals with these mutations, if they do develop a colorectal cancer, ideally, if they are capable of withstanding the procedure, would be recommended for total colectomy. That would ultimately reduce their risk in the future of a secondary malignancy of the colon. It's also important to talk to these individuals about reproduction, and women especially that are done with their childbearing should be referred for consultation with GYN Oncology to talk about a risk reduction hysterectomy. Again, it's important to know family history in these individuals because you can also identify if individuals are at risk for Lynch syndrome based upon their family history. So all of those cancers that I mentioned, if an individual has 3 family members with those cancers, that is called Amsterdam criteria, which meets eligibility guidelines to test them for their risk of a hereditary cancer syndrome. Now, if any of those individuals in that family has ever been tested and proven to have a polyposis-related syndrome, such as familial polyposis, which we'll talk about next, or the MUTYH-associated polyposis, then that excludes them from the possibility of Lynch syndrome. We also test individuals when they're found to have colon cancer if they're at risk for Lynch syndrome. We do a test called microsatellite instability, looking at the 4 main genes associated with Lynch syndrome. Again, those are MLH1, MSH2, MSH6, and PMS2. And if there's nuclear instability in those genes on the tumor tissue, which again is somatic testing, that suggests there's a potential increased hereditary risk. The next syndrome associated with colorectal cancer and risk in lifetime is familial polyposis, and there are 2 varieties of this. There's a classic variety and an attenuated variety. The attenuated variety, as it may sound, implies a lower risk than the classic variety. This is a mutation of the APC gene, and individuals of the classic variety of this have an overall 100% risk of developing colon cancer in their lifetime. So it's obviously very important to know who these individuals are before they're affected. And when we know this runs in families and can identify this even in children, we begin screening colonoscopy as early as 10 to 12. And this is performed on an annual basis until polyps become burdensome. So either they're symptomatic, or they are causing bleeding, or they're affecting the patient in one way or another. At that point, generally the treatment of choice would be total colectomy. The attenuated version of this, patients are at a lesser risk, of course, as I said earlier, but still their lifetime risk to develop malignancy is as high as 80%. So again, it's very important to identify who these individuals are. They're also at risk for tumors known as desmoid tumors, which are not malignant tumors in and of themselves, but can cause significant morbidity. It's important to know who these patients are, because the more intervention they may have, so the more surgical intervention they have, the increased likelihood they have of developing desmoid tumors. As far as the MUTYH-associated polyposis, the overall screening for them is similar, and this is a mutation in the MUTYH gene. They are screened frequently by colonoscopy, and once polyp burden becomes severe or a cancer develops, then surgical intervention is recommended. Screening for Lynch patients would include colonoscopy every 2 to 3 years, as well as annual dermatologic exams, and then close follow-up with GYN or GYN oncology until a decision is made to have a surgical intervention to have a risk reduction hysterectomy. Next, we're talking about genodermatoses. So what are genodermatoses? These are cutaneous manifestations of genetic mutations. So the reason I wanted to talk about these is twofold. If anybody is familiar with my practice, in addition to seeing a lot of colon and hepatobiliary patients, we see a lot of skin and soft tissue patients. So this is something that is sort of near and dear to me, as I see this a lot. But the reality is, so do all of you. You see all this at the bedside. You see these skin manifestations, and though you may not know what they are, you can tell that it's not something that you normally see. So I chose the most common ones that we may see to talk about here. We could spend an entire talk on this. We could spend an entire day talking about these. But first I wanted to talk about something called Gorlin syndrome. And this is a mutation in the PTCH gene. And this puts an individual at an increased risk to develop basal cell carcinomas. These are non-melanoma skin cancers that typically we see in older individuals or individuals that are immunosuppressed. So perhaps our transplant patients. But when we see these tumors in very young patients, and especially when we see numerous instances of these tumors, it should raise a red flag that, hey, something's not right. In addition to multiple basal cell carcinomas, these individuals have macrocephaly, or very large heads, as well as hypertelorism, where their interpupillary distance is large. Next is Peutz-Jeghers syndrome. This is a very rare autosomal dominant mutation with very distinctive mucocutaneous pigmented lesions or multiple dark spots within the mouth. These individuals are prone to immunosuppression, and as a result are prone to malignancies compared to unaffected individuals. This is a mutation in the STK11 gene. Next we have neurofibromatosis, which was what was illustrated with the image on this slide. There are actually 2 types of neurofibromatosis. Type 1 is associated with a mutation in NF1, which makes sense. Those kind of go together. This is also known as Recklinghausen's disease, and these individuals have characteristic cafe au lait spots or little spots that look like little pools of coffee on their skin, and are also prone to the soft tissue tumors that were illustrated on this slide. These individuals are at increased risk for sarcomas, which are soft tissue tumors. There's also neurofibromatosis type 2, which is a mutation in the NF2 gene. Again, that makes sense. These individuals are at risk for tumors of nerve sheaths, specifically of the vestibular nerve or acoustic nerve. And often this will present as a unilateral hearing loss at a very early age, in the 20s. These individuals are also highly sensitive to radiation, so again, it's very important to know who is affected by this, both for screening purposes, but also for appropriate treatment if a malignancy should develop. They also have characteristic cafe au lait spots, but they tend to be much larger than NF1 patients and less pigmented or less dark in color. Finally, we have ataxia telangiectasia, or Lewis-Barr syndrome, which is a mutation of the ATM gene. These patients suffer progressive cerebral ataxia. They also are prone to immunodeficiencies and as a result are prone to malignancies in later life as well as type 1 diabetes. Finally, as far as our genetic syndromes, I wanted to talk about a handful of mutations that are associated with individuals with an increased risk for multiple cancers. Because the reality is we see this. I can think of easily a handful of patients that I've seen with this within the last year. First, we start with something called Li-Fraumeni syndrome, and this is a mutation in a gene called P53. These individuals are unfortunately at an increased risk for breast, sarcoma, brain, leukemia, adrenal gland cancer, and it is a very highly penetrant gene, meaning these individuals with this mutation are very likely to develop these cancers, and it's a very highly penetrant gene in women compared to men. One reason for that is, quite frankly, we see this more often in women than we do men, so I think that's the population that we really have represented. Unfortunately, the risk of cancer in the overall lifetime approaches 100% in this mutation. Next is von Hippel-Lindau syndrome, which is another autosomal dominant syndrome associated with a mutation in VHL. These individuals are prone to tumors such as hemangioblastomas of the brain, clear cell renal cell carcinomas, pheochromosarcomas, and then serous cystadenomas, as well as neuroendocrine tumors of the pancreas. The average age of presentation in mutant individuals with VHL mutations is 26. There are two types. There's type 1 and type 2. Type 1 has a lower risk of developing pheochromosarcomas and a higher risk of the other tumors, whereas type 2 has a higher risk of pheochromosarcomas and a lower risk of the other types of tumors. Next, we have multiple endocrine neoplasia type 1 and type 2. Multiple endocrine neoplasia type 1 is associated with a mutation in MEN1, again, fitting considering the name. These individuals are at an increased risk for tumors of the parathyroid, anterior pituitary gland, as well as pancreatic endocrine tumors, duodenal carcinomas, adrenal adenomas, and lipomatous tumors. MEN2, conversely, is associated with an increased risk for medullary thyroid cancer, as well as Hirschsprung's disease and amyloidosis. This is where it doesn't make sense, as this is a mutation in a gene called RET or RET. So in review, we've talked about genes, we've talked about DNA, different mutations, and how they are manifested in individuals. What's the relevance of all this? Nurses at the bedside, nurses in the outpatient setting, we have a fairly strong relationship with our patients. We often get into a lot of depth talking about their medical history, their family history. That puts us in a very unique position to provide this service or help guide this care for our patients and identify those individuals at risk. This is all about preventative medicine. When we identify folks at increased risk, we have ways to provide surveillance and screening to either identify a cancer before it occurs or very early, so perhaps it's less morbid for that patient. This is an exciting new field. I think as nurses we are well suited for this, and we are in a unique position to really provide this as a really good service for our patients. It's also a way we can collaborate with our other colleagues, our physician colleagues, our genetic counselors, our geneticists, our pathology colleagues, and really take a very active role in our patients' care. That concludes this month's talk.